Disclosures. This project was funded by Metronaut Hospital Health Service Collaborative Research Grant in 2020. And I'd like to thank the statistician who's been giving me some friendly advice now and then, and participants for allowing me to use their samples. And I've got no conflict of interest to disclose, other than the fact that I have got very basic knowledge in hematology. Sorry. I was supported by this whole team of investigators, and I would like to thank each and every one of them wholeheartedly. Now, I'm the third person to thank the Okamoto couple, Utako and Shosuke Okamoto. So they worked on this maternal mortality due to postpartum hemorrhage, and they published this in 1962. And apparently, when the women trial reached its 20,000 patients or something, she was asked about how she felt about the results just a few months before she passed away. And these were her words. It says that I'm absolutely sure it's going to be effective. I don't need the research to know this. So this was a confidence of a good researcher. And 60 years down the track, we are still talking and having symposium on this. So a bit of background. I'm not going to discuss the mechanism of action of tranexamic acid, but what I would say as a clinician, tranexamic acid is widely used in all the surgical contexts, and particularly in cardiac and orthopedic is what I'm going to focus on. It's widely used in hip replacements. It's supported by all the perioperative guidelines, so we need to use that, and it's better than placebo in reducing blood loss and all that. But it's all based on RCTs, and we all know RCTs, the healthy patients are cherry-picked. And also, I would say it is based on the bleeding endpoints, clinical endpoints. Bleeding endpoints, we know it's very, very notoriously inaccurate. And there's a lot of hidden blood loss in hip replacement. It's about nearly 30% of the total blood loss. Transfusion triggers, again, it depends on the patient's cardiac stability, the institutional practices, my practice, your practice, all that kind of stuff. And anemia, it depends on, again, the preoperative iron supplements and anemia management programs. There's a lot of confounding factors that will impact on the accuracy of clinical endpoints. And therefore, we have got this wide variation in dosage. There is inconsistency. So I give a gram, my friend might give a gram, followed by a gram 8 hourly or infusion, and then every country is different, every institution is different. So what we need is a robust PKPD modeling based on the which has a mechanistic basis. So that will sort of guide us to what the correct practice is. These are all there in cardiac and pediatric surgery. Obviously, we can't extrapolate those things because of the age difference, comorbidities are different, anticoagulant uses are different, cardiopulmonary bypass, so on and so forth. And even them, the majority of them, have their PD endpoints of bleeding, or they have ROTEM, and I don't really agree with those. Anyway, so hence, I'm just going to, so this is a PKPD study, but I'm just going to focus on the fibrinolytic changes. So anyway, I'm not sure how many of you know of this famous doctor who's popularized lysine, and he founder of the theory lysine contingency. So I know a little bit more than the hematologist. So lysine is an essential amino acid, so it is actually helpful in absorption of calcium from the bone and cholesterol, lowering cholesterol, so on and so forth. And lysine depletion apparently is disastrous. And therefore, what this widely published person did was to genetically modify the dinosaurs so that they depend on the zookeepers for lysine supplements so they could not leave the park. And you probably have seen this movie too, or read this book. So he did publish a lot of papers. Coming back to science, so I just want to set the scene by mentioning about two studies. So one is Blaney study. Blaney and their team, they looked at the fibrinolytic changes after total hip and knee replacement. So I'm just going to focus on the hip replacement. So they recruited 14 patients who had undergone hip surgery, placebo arm, and the tranexamic acid. So they gave this dose of tranexamic acid. So in the placebo group, you can see that what you can see in the graph is the D-dimer changes over the first 24 hours. So you can see that it actually progressively increases. There was a significant increase in the placebo placebo arm, reaching the peak level at 6 hours, and then it sort of drops down, but still above the baseline. And tranexamic acid, sort of, these fibrinolysis is suppressed significantly. So that is just to show that the fibrinolytic activity actually changes perioperatively. And the second study is in the trauma context. Moore and their team, they categorize patients based on the ROTEM. I think it was ROTEM. So they categorize into fibrinolytic shutdown, physiological fibrinolysis, and hyperfibrinolysis. So what you can see is the physiological fibrinolysis has got the lowest mortality. That's pretty intuitive. And when tranexamic acid was given, the physiological and hyperfibrinolysis showed an increased mortality rate. But when adjusted for injury score, just the physiological fibrinolysis had increased mortality. So my point is not about which phenotype is associated with mortality, but just to show that tranexamic acid response seems to be based on the fibrinolytic status of, that's there in at that particular time. So we embarked on this studies to perform, the aim of our study was to perform in vivo population PK/PD study in adult patients undergoing total hip arthroplasty receiving intravenous tranexamic acid, and to optimize the dosing regimens of TXA. We established antifibrinolytic concentration of TXA using the TPA-induced clot lysis assays, and we also looked at other markers of fibrinolytic activation. So this was a prospective single-center study in adult patients undergoing hip arthroplasty under general anesthesia. We excluded patients who were at high risk of thromboembolism and stage renal disease, just mainly for the feasibility of that study. Otherwise, anesthetists wouldn't be happy to give TXA. 15 milligram per kilogram intravenously was administered 30 minutes before incision, and samples were taken at various time points. Baseline skin incision, skin closure, 6 hours and 24 hours. And fibrinolytic parameters were examined. So 24 patients were recruited. So this is just a slide that is actually showing all the results. So if we look at the clot lysis assays, you can see that with skin incision and skin closure, the fibrinolysis is inhibited markedly, and then there's a partial restoration of fibrinolysis at 6-hour mark, and then at 24-hour mark, it's almost back to normal. So if you look at D-dimer results in the PAP assays, the trend looks almost similar. D-dimer, the baseline D-dimers were elevated. You can see that from skin incision onwards, it's increasing. And the PAP is also following the same trend, although the statistical correlation was significant at 6-hour mark. And if we look at the ROTEM, the ml maximum lysis was more than 15%, was defined as hyperfibrinolysis based on previous studies. And just 2 patients has shown this kind of response at 24-hour mark. So this is just to show that again. Now, just to summarize the finding, there were discrepancies between the fibrinolytic assays. D-dimer was elevated at baseline, and then it fluctuated over the 24 hours. PAP and D-dimer followed the similar trend, increasing level of PAP and D-dimer from skin incision to 6 hours post-surgery, and then it drops at 24 hours. In contrast, clot lysis showed a significant inhibition at skin incision, skin closure, and partial inhibition at 6-hour mark. And ROTEM, as I mentioned before, showed hyperfibrinolysis picture at 24-hour mark. So the focus of the changes or the discrepancies at skin incision, skin closure, and 6-hour mark sort of attracted our attention, because that's where the surgeons are really concerned about blood loss. So what happened in our study was the clot lysis was significantly inhibited, but the PAP and the D-dimer was showing an elevated levels. And this sort of looking at the evidence that was available, we looked at the sub-study that was published from the EDICAS trial patient, thanks to Miles and Draxler for letting me borrow. So anyway, so the PAP levels, so these were patients who had either placebo or tranexamic acid at 50 milligram per kilogram. Blood samples were taken at various time points, pre-operative, end of surgery, and post-operative day 1 and day 3. I'm just going to focus on the PAP results, although there are other tests that were done. So if you can see the pre-operative, the baseline till the end of surgery, there is a surgical trauma-induced PAP level increase. But when the tranexamic acid was given, there is a substantial increase in the PAP levels, and the end of surgery tranexamic acid increase. Looking at that could potentially be because of plasmin generation. That is a possible theory. In comparison to our study, Atticus trial did not show any D-dimer increase, and that could, again, that's just a theory. It could be because of high dose of tranexamic acid. We gave 15 milligram, and this is 50 milligram. That is possible. This is not our primary endpoint, so we didn't get to prove this. It's just an observation and the plausible theory behind it. If anyone can come out with a different theory, please feel forward. The ROTEM, again, we all know that it's got a bit of a low sensitivity for reduced fibrinolysis and potentially for hypofibrinolysis as well. And the 15% is based on other studies in trauma. Another paper has said 13%. So the validity of that threshold in arthroplasty setting is, again, questionable. So we can't make conclusions based on that. So just to complete my presentation, just the PK result, it was a 3-compartmental model was the best model. And after 15 milligram per kilogram dose, if you see the concentration was before that, the 90% clot inhibition was achieved by 10 milligram per liter. So that was decided as a PK therapeutic target. So after 15 milligram per kilogram, 4.94 hours was the median duration above which TXA level was sustained. Then if you look at this, then after the 15 milligram per kilogram of bolus dose, this is where the TXA level was above. This is how long the TXA level was above the 10 milligram per liter. And the right extreme column shows the duration of concentration about 10 milligram per liter. And so what we did, Monte Carlo simulations, we did 1,000 patient PK profile, tried different regimens, and then we came, the pharmacokinetic experts came up with this particular dosage as the effective antifibrinolytic dose for total hip replacement. So in conclusion, fluctuations in fibrinolytic activity occurs following hip arthroplasty. With the current dose of TXA, it is possible that certain degree of plasmin formation occurred. The dosage that we have come up with, we are not sure if that can be translated to clinical endpoints, if that is the lowest minimum therapeutically effective dose. So we haven't tested that far. We just know that this is the optimal in terms of antifibrinolysis. So that needs further research. And of course, the pharmacodynamic changes, again, needs further studies as well. So thank you.